Our next speaker is going to be speaking on use of total keratometry in IOL power calculation. Is it a game changer? And the speaker is Colonel Madan Deshpande. Dr. Barucha.
Respected chairpersons, members of the audience, a very good morning and greetings from HV Desai Eye Hospital. My talk is on use of total keratometry in IOL power calculation. Is it really a game changer? Cataracts, as we know, is a leading cause of remediable blindness. Cataract surgery has evolved from what used to be just a vision restoration surgery to a more refined refractive surgery. Technology is now available to reach this goal. An accurate pre-operative measurement of optical biometry is the key for a precise post-operative outcome. Cornea, as we know, is the most powerful refractive element of the eye, contributing about 70% of the refractive power of 43 diopters. Anterior surface contributing about 48 diopters and posterior a -6. Keratometry started as early as in 1619 when a Jesuit priest called Christoph Schneider started studying the corneal curvature and tried to measure it. Over the years, it got better, and we developed a keratometer for clinical use. Standard keratometry relies purely on measurement of anterior corneal surface. Traditionally, keratometry is measured assuming a fixed corneal posterior to anterior ratio or a Gulstrand's ratio. And it's calculated using a standard keratometric index of 1.3375. The anterior curvature, the posterior curvature, and the corneal thickness, all three contribute to the total refractive power of the cornea. So ignoring the posterior corneal curvature may lead to inaccuracies and significant overcorrection or undercorrection. The IOL Master 700 is a swept source OCT-based optical biometer which we used in this study. This machine first builds an anterior toric model with telecentric keratometry and then measures the pachymetry using a swept source OCT. The pachymetric values are then fitted onto the anterior toric surface model to create a posterior toric surface model. And then total keratometry is calculated using the anterior, the posterior corneal curvatures, and the corneal thickness. Pentacam and Sirius also use Scheimpflug imaging for measuring the posterior corneal curvature. In this study, we aim to compare the predictive accuracy of standard keratometry versus total keratometry in IOL power calculation, and we did the same for monofocal IOLs as well as toric IOLs. It was a prospective cross-sectional comparative study over 1 year. Patients over the age of 40 undergoing routine phacoemulsification with monofocals and toric IOLs were recruited. The availability of preoperative K and TK data from IOL Master was mandatory, and patients having more than 1.5 diopters of astigmatism were advised to go for toric IOLs. We had two groups, one for monofocal, one for toric. The IOL power for each patient was derived using both standard as well as total keratometry. Barrett Universal 2 and Barrett Universal TK calculator was used for monofocal as well, and Barrett Universal Toric and Barrett Toric TK was used for toric IOL calculation. Standard phacoemulsification with 2.8 millimeter incisions. Post-operative refraction at 1 month after surgery was measured by automated refraction, manual refraction, and confirmed subjectively. Absolute predictive error for K and TK was calculated. Absolute predictive error was the actual post-operative spherical equivalent minus the pre-operative predicted spherical equivalent. So we had 100 patients in both the groups, average age of 68, 40% females. We measured the average K for monofocal group as well as toric group, and we did not find much difference, statistical significant difference between the two. While for average astigmatism in the monofocal and toric group, we found a statistical significance between the two. Absolute predictive error in monofocal group, we did not find any significant error, p-value of just 0.2. While in the toric group, we found that absolute predictive error of total keratometry was significantly lesser than for monofocal IOLs. So just to sum up, in group A, the absolute predictive error between K and TK did not make much of a difference, which was monofocal IOLs, while in toric IOLs, it was significantly lower for total keratometry. Some other studies also have corroborated our findings, And so with the advent of new technologies, we can use TK, which is available in machines like IOL Master 700 for toric IOLs, but for monofocal IOLs, it did not seem to make much of a difference. Our references, thank you.
Yeah, Wing Commander, your Wing Commander Khurshid.
Yes, sir.
Very nice study. But could you please tell me why did you not choose to go for a toric IOL if it's around 1.5 astigmatism?
We did
You
above
go
1.
beyond that.
Yes, sir. Yes.
Above 1.5 you go.
So
Usually plus
if it's with the
one,
rule,
within-
you take above 1.5, and if it's against the rule, then you take about 1 as the cutoff.
Okay.
So all your cases were with the rule?
Pardon?
Were all your cases, because you took standard as, in the methodology, as above plus 1.5.
The toric IOLs were above 1.5, yeah.
How, what was the sample size of the toric
100,
group?
100 each in monofocals as well as toric. Yeah.
Okay. Thank you.
Thank you.
Thank you, sir.